Alright, so this will be our last lecture for Module 2. Typically, just historically, I really prefer doing the lung and the cardiac assessment within the same module, but when they restructured the course, they kind of laid them out a little bit different. But just keep in mind, typically when you do your respiratory assessment, you kind of just follow right into your cardiac assessment because they're all within the chest cavity for the most part. So, okay. Again, just kind of this disclaimer, there are a lot of techniques on this respiratory or lung assessment that you would not use on a normal, everyday head-to-toe assessment, but there are some additional variables that we will cover just to give you a little extra techniques or exposure to some of the extra techniques that you might see some providers do, or even some more advanced practitioners or ICU nurses, so on and so forth. Okay. All right. The thorax and lung assessment. Again, the thorax basically starts at the base of the neck, and then it goes down to the level of the diaphragm. And that's anterior and posterior, front and back. The lungs are the distal portion of the trachea, the bronchi, and then out to your lung fields. Some structures of the thorax and lungs, mediastinum, that's that central cavity in the thoracic cavity, kind of that central area. You have the lungs, those are those two cone-shaped kind of elastic structures that flank the mediastinum. And then the pleura, you have these thin layers of tissue that surround the lungs and that have some lubrication in it that kind of lines that thoracic cavity. And it lets all the organs kind of like easily glide against each other. That's called our pleura. Lung cancer, just kind of a history. Lung cancer is the leading cause of death in the United States and Europe currently. It is dropping though, because we don't have as many cigarette smokers as we used to, which is a good thing. Again, the number one risk factor obviously is going to be cigarette smoking. There's also a genetic disposition for some clients who develop emphysema. Exposure to toxins, and that's like pollutions, can have a significant correlationship with lung cancer. Also, history of previous lung cancer, and gender. Men are more frequent than women. Lung cancer risk, again, join a smoking cessation program, stop smoking, healthy, low cholesterol diet, limit the exposure to your toxins. We'd like to do a lot of teaching with our clients when you get into the nursing program. Lung cancer prevalence, again, lower in some other countries. Again, African American men have a higher incidence and higher mortality rates in the United States. And Hispanics have lower rates than non-Hispanic whites in the United States. Again, we always have lots of teaching opportunities, and I know normally we introduce these things to you in the nursing program itself, but just to kind of prepare you, because we see such a high incidence of clients with COPD, breathing problems, typically related to cigarette smoking and or toxins. We like to introduce these to you a little bit early just to prepare you how to teach about smoking cessation, look for any type of occupational or home hazards, toxins, asbestos, radon, and very important to avoid secondhand smoke as well. We always worry about our pediatric population and that correlationship with asthma and upper respiratory infections or respiratory infections. And when to seek medical assessment or see a doctor regarding respiratory systems such as a prolonged cough or chest pain in the chest area or in the lungs. All right, so here's some thoracic landmarks. Again, here's our mid-sternal line, because you got the sternum that falls along through here. Mid-sternal line. This is called your mid-clavicular line, and this is also your right mid-clavicular line. If you look at the clavicle, this is right in the middle of the clavicle. Same here, clavicle, right in the middle of the clavicle. And pay very close attention to your mid-sternal line and your really your left mid-clavicular line. You're probably going to use those more so than the right because you have the heart over here as well. And posteriorly, the left scapular line, the vertebral line, and your right scapular line. So those are our landmarks that we'll be using. Anterior axillary line. Again, this is under the axilla, under the armpit or the axilla, and your mid axillary line is directly in the middle under the armpit. If he had his arm extended out versus forward, this would be right up underneath his axilla. And then the post axillary line. I wish he had his arm turned a different way, so it would really kind of show up that this is anterior, mid, and post. But again, you can kind of see that thoracic cavity there, and you can see this is kind of where your lung field would be, and the ribs, and so on and so forth. Here is a picture of the bone structure in the thorax. Again, here's your clavicle. Rib 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Go on down. Your diaphragm is up under here, just below or just underneath, the sternal, the xiphoid process on the bottom of the sternum. I encourage you guys to feel for your own ribs. Become very familiar with how to find these, what we call the intercostal spaces. And this is an intercostal space. It's the space in between the ribs. So this is the intercostal space between 1 and 2, the intercostal space, the second intercostal space, the third intercostal space, fourth intercostal space, because we use those intercostal spaces to identify different structures in different areas as well. And also when you're listening, it's best if you don't listen over the bone versus the actual intercostal spaces, because sometimes it can, or when you do some percussion, it can alter the sounds that get elicited. So identify your intercostal spaces in your ribs, and become quite familiar with being able to do that. That suprasternal notch, this is the manubrium of the sternum and the xiphoid process. And posteriorly, again, you have your clavicle, you have your vertebra, and your scapula. Lobes of the lung. Pay attention, you have 3 lobes on that right and only 2 lobes on the left. Again, because the heart sits right in here, and kind of takes up that space right there. And here is where it looks at posteriorly. You will not be able to hear that right middle lobe on your posterior. Posterior is usually right upper or right lower, left upper, left lower. That right middle lobe, you can only really elicit sounds, or hear those sounds anteriorly, okay, from that approach. You can, though, if you go under the axilla on the side of the lungs, left upper, left lower, you can hear it on the right upper. You have that right, the right mid lung, and then you have the right lower lung. All right, I do kind of want to go over these respiratory patterns, because we need to start using medical terms, and hopefully you're somewhat familiar with some of the technical terms that we go over. Your normal breathing pattern for an adult is 12 to 20 breaths per minute. It's going to be more if they're exercising or if they're short of breath due to exercise or maybe even a fever. They might be a little faster. And if it's faster than about 24 breaths per minute, we call that tachypnea. Anything you hear the word tachy means fast. So tachypnea is rapid breathing faster than about 24 breaths per minute for an adult. Slow breathing, on the other hand, may be because of medications. It may be a brain injury, maybe some other concerns going on, and it's usually kind of an emergency. Excuse me. But we call that bradyapnea. Again, anytime you see that prefix brady means slow. So bradyapnea, slow breathing, less than 10 breaths per minute, and regular would be bradyapnea. Hyperventilation, I think most people know what hyperventilation is. It means that they're just increasing the rate and increasing the depth. A lot of times we see that with anxiety, and some other issues, but we see that a lot with anxiety. There's a breathing called Kussmaul's breathing. You'll learn more about this when you get into the nursing program. We associate that with our type 1 diabetics. It's because they get a pH balance within their imbalance when they get really high blood sugars. And the body tries to compensate by breathing off all this extra carbon dioxide. So they're trying to breathe all this stuff off, basically, and that causes a very rapid, labored breathing. And once you see it, you probably won't forget it. And it also kind of has a fruity smell to it. But anytime you hear Kussmaul's, you're going to associate that with what they call diabetic ketoacidosis. Kussmaul's is for diabetic ketoacidosis for a type 1 diabetics. Hypoventilation, usually they just have a decreased rate and decreased depth. They're not breathing as fast or as deep as they should. Again, usually that we might associate that with the overdose of narcotics, and that has skyrocketed in the last 10 to 15 years is our opioid dependence and deaths due to opioid overingestion. So be familiar with what hypoventilation looks like. Cheyne-Stokes, it's a very irregular pattern by periods of rapid, then deep, then slow, and then periods of apnea where they're not breathing at all. Usually see Cheyne-Stokes breathing with clients who are at the end of life, who have had a severe brain injury. So, Cheyne-Stokes, that's typically when you're going to see those types of breathing patterns. Biots, again, might be related to some type of brain damage, irregular pattern by varying date and rep, followed by periods of apnea. Ataxic, it's a more extreme expression of the biots. And then air trapping, usually that's something that we see with our clients that have that lung disease called COPD or chronic obstructive pulmonary disease. That's typically what we associate with our long-term smokers. They get a lot of air trapping in their lungs. It's like they can breathe everything in, but because of the changes in the structure of the lungs, they have trouble getting all their air out, and it kind of makes their chest kind of have a barrel shaped. So that's called air trapping. Of these, I think of what you should really be pay attention to what I have on your study guide. I did list some patterns on there, the ones that you should really probably focus on for your exam. All right, normal breath sounds. We have basically 3 types of breath sounds. You have your bronchial, vesicular, and your vesicular. And it shows where you are going to, and it just depends on where in the body you're listening. Your bronchial sounds are going to be listened, you're going to hear those over the trachea and the thorax. They're really high-pitched and kind of harsh sounds. So if you're listening over the trachea and over the thorax, kind of like over the main bronchial stem, right there in the manubrium, that's really where you're going to, at the upper manubrium, at the upper part where that sternal notch is, that's where you're going to hear your bronchial sounds at. Your bronchial vesicular, again, are going to be over the anterior, on the posterior between the scapula area, and anterior on the upper part of that sternum, and between the first and second intercostal spaces. It's kind of where the bronchial tree starts to branch out, but it's not quite to the lungs yet, okay? And then your vesicular sounds, that's basically your lung fields, those peripheral lung fields, your right lung, all 3 lobes, the left lung, both lobes. Those are those low, breezy, soft sounds that you hear out in the lung fields. So you'll need to have to be identify where you are hearing what sounds when you do your assessment. Your bronchial sounds, your bronchiovesicular, and your vesicular. And I did show that in my demonstration video as well. Here is the location of those normal breath sounds. Again, here's where you're going to see that bronchial sounds right here around the trachea and just above that manubrium, above the sternal notch. Your vesicular sounds are going to be out here in your lung fields, and your bronchial vesicular are just, again, along the bronchus and right there along that bronchial tree. Okay. All right, here's the posterior locations, and again, you're not going to have those bronchial sounds posterior, just bronchiovesicular, and then your vesicular sounds. Auscultations tests, we're going to kind of scale back on some of this because a lot of this you may never really ever see. There's a few additional tests that you might see some providers do called a whispered pictorially. That's when your client, you have them whisper and you try to see if that sound is able to go through those hollow air-filled chambers when you're auscultating their lungs. There's bronchophony and agophony. We really only do these if we suspect they have fluid in the lungs. And again, this is really more for an advanced practitioner or physician, and it's not something we'd necessarily expect you all to do at this point anyway. But feel free to review some of that information on your own if you choose. Again, that whispered pictorially, I kind of went over that. The client's going to whisper. And normally when you auscultate the lungs, you would hear a very whispery, breathy type of sound. If it's really loud or even clear, remember sound waves will go through fluid much easier than it does through air. So if there's fluid in the lungs, it's going to sound louder. So that's why if it's soft and breathy, it would be normal. Abnormal is if you hear it louder and more clear because of that fluid. Egopony, again, you're going to listen with your stethoscope while the client says E. And again, I normally hear that long E sound, but again, if there's fluid in the lungs, it kind of distorts it to make it more of an A sound over those area of consolidation. Again, it's because of the fluid in the lungs and how the sounds will travel through fluid versus air. Abnormal breath sounds. Again, we want you to pay attention to these because you won't necessarily be subjected to them in this course, but they are going to hold you accountable for them once you start your nursing program. You have fine crackles, and it sounds very fine but crackly. Coarse crackles, they're a little bit heavier, but again, sounds crackly. We have sibilant wheezes, sonorous wheezes, stridor, and that should be stridor, T-O-R, and what's called a pleural fiction rub, and we'll kind of go over these. Fine crackles, again, high pitched, short little popping sounds. You can hear them both during inspiration, and they won't clear with a cough. Okay, that's very, and they're usually they're going to be heard, excuse me, they're going to be heard over your vesicular lung fields. The same with the coarse cracklers. There's just going to be some lower pitched, bubbling, moist sounds that are heard, oh my gosh, heard over your lung fields. Again, usually it shows that there's some type of inflammation or pneumonia or some type of obstructive disorder with the alveoli. If you think of those little grape-like clusters within the lungs, there's usually got some problems going on within there. Anytime you hear these crackles, that's what you like to associate with either pneumonia, pulmonary edema, some type of fluid, or some fibrosis. That's when those little alveoli get a little stiff, and we hear those. Okay. A pleural fiction rub. Remember I told you that we have different layers that kind of surround the lungs. You have certain conditions, if they have a lot of inflammation, where these layers of will start to rub on each other, those pleural surfaces, and that's actually what you hear. The best way to describe it in my experience is if you take your hair and you kind of rub it between your ear, or rub it between your fingers right outside of your ear, and it sounds like a very fine rubbing sound. That's called a pleural fiction rub. It's very hard to identify, especially as a novice nurse. We'll talk more about that probably when you start your nursing program, but just kind of be aware of it, that there is something called a pleural fiction rub. It's again, it's the result of those pleural spaces kind of rubbing against each other because there's a lot of inflammation in the body. Wheezes, again, typically you're going to hear it over different in constricted passages. That's when you have a lot of inflammation in the passages, airway passages, and there might be some secretions. Asthma and also emphysema, you'll tend to hear a lot of wheezing going on. You'll have sibilant wheezes and sonorous wheezes. Sibilant wheezes are typically more with like asthma, high pitched, heard more during expiration, but you can also hear it on inspiration. Whereas the sonorous wheezes, you can hear on expiration, but also throughout the entire respiratory cycle. So there are your wheezes, your pleural friction rub, and your crackles. Those are going to be your most common. And I do have some links for some breath sounds, and I'm going to make sure I leave those for you guys to kind of listen to. Be aware that it's really difficult to elicit really good breath sounds, and the recordings are always not the best, but I will do what I can to get those recordings for you. Stridor, again, is something that typically we see with little kids. It's kind of a harsh honking sound. Sometimes we see it with croup a little bit, but it's really audible. It's kind of like if somebody's really having a tough time breathing and they make that sound, that's stridor. You can hear it over the neck or audible with the stethoscope. It's because they have a very narrow airway, either from laryngeal spasms, whooping cough, or if they have a foreign object in their airway and it's making that noise. It's usually going to be right there in that upper airway. That's called stridor. All right, if we percuss the chest, and again, this isn't something that you would do probably on your everyday head-to-toe assessment, but we do want you to be familiar with how to do this technique, and we do have you practice this. Resonance, hyperresonance, dullness, flatness, and tympany. I know I went over what these kind of sounds went, but beforehand, I don't know if this links works anymore. We can try it. Nope. I think my link is broke. Yeah, that's all right. Resonance, again, normal sounds. They're percussed over the lungs. That's because they're air-filled, and it should have a nice hollow tone to it, especially if you're doing it within those intercostal spaces, not over the bones. Hyperresonance, it's because there's too much air trapped in the lungs. Again, typically you're going to see this with someone with emphysema or COPD. Because of those types of disease process, they get a lot of air trapping, and it actually changes the structure or the shape of the lungs. And it sounds more of a booming sound, like emphysema or even possibly a pneumothorax. Dullness, it's usually over some organs, masses, or even some fluid. Sometimes if we're percussing, especially down in that lower, or along the lower intercostal spaces, you might percuss over the liver. If you're on the left side, it might be the heart, possibly tumor, or even if there's some consolidation or fluid within the lungs, you might hear some dullness under percussion. Flatness, that's usually going to be a bone. Usually if you're not getting in that intercostal space and you're actually percussing over a bone, it'll be a little bit flatter. And I encourage you guys to practice this at home. Find someone and percuss with their intercostal spaces, and then go over a rib and then percuss there and see how the difference of the tone is. It really does make a little bit difference of a tone. You can hear the flatness over obviously the ribs, the sternum, and if there's atelectasis, and that's basically those little alveoli kind of collapse on top of themselves because they don't have any air in them. That's called atelectasis. I don't think you're going to be familiar with that for your exam. I don't think so. That should be something that you should probably be more subjected to once you actually start the nursing program. Tympany is really kind of like a drum sound, and you can hear it mainly over the gastric bubble, and that's kind of like the stomach area. Sometimes you hear that tympanic sound because you have a little bit of air in there. Again, you want to get a good history on your client. Do they have any breathing difficulties? And if they do, what's the pattern? Is it with rest, only with activity? Do they have to sleep with a pillow kind of sitting up? Does it help them breathe a little bit easier? Do they have a cough? And if they do, when do they cough? Is it in the morning? Is it all the time? Has it just been recently? Has it been a chronic cough? Is it productive or non-productive? And that just asks them, do you produce anything with your cough? If they do produce anything, what does it look like? That's called the sputum. What does the sputum look like? What is the color of it? What's the consistency of it? And do they have any chest pain? Some respiratory disorders include asthma, bronchitis, emphysema, tuberculosis, some medications, and again, environmental concerns. Do they smoke? And if they do, we'd like to know how many pack years they've smoked, how many packs per day, and how many years. Do they work in an environment with pollutions or pollutants, such as a coal or a chemical pump, or a coal mine or chemical plant? Then just have them prepare for the assessment. You're going to need your stethoscope and perhaps a ruler. Not on a typical head-to-toe assessment, but if you're doing a more in-depth focus assessment, you might need a ruler. Just explain your assessment to your patient. Just ask them and dress from their waist up. And just remember inspection, palpation, percussion, then auscultation, same order as with all our previous assessments. And we always like to compare the left to the right side and then go from back to front and from the top to the bottom. I think when I did my demonstration, I kind of went back and forth a little bit, but typically, I was kind of thrown off trying to do these assessments in my basement and trying to get them done for you within a reasonable amount of time. But typically we have to go left to right because you want to compare side to side. You're going to compare like the left side to the right side of the lung. And then once you do your posterior assessment, then you'll do your anterior assessment. And after your anterior thorax assessment, then you just kind of gradually go into the cardiac assessment because you're going to be on the anterior side anyway. All right, with positioning, again, just try to maintain privacy. If you have a female, you have them use the gown. In a clinical setting or in sim lab, it's imperative that you use your stethoscope to skin. We understand with your videos and we're allowing you to provide for some privacy. We don't want you to expose your partners, but we do want you to verbalize those landmarks and where you're placing your stethoscope and what have you, since we can't actually see you place your stethoscope on those landmarks. But remember, when you start the nursing program or when you're in sim lab, you will do stethoscope to skin. All right. Ideally, we like to have the patient standing or sitting, whatever their position of comfort is. When you assess the posterior thorax, don't forget the spine because you're right there and you can kind of look at the spine and watch for tripod sitting. And if you look at this gentleman over here on the right, he's kind of sitting up and sitting forward. If you look at the shape of his chest, he has kind of a rounded shape to his chest. This client is the client that has emphysema. Just by looking at his chest, you can look where it's concave a little bit because he's having some difficulty breathing. He's using all these accessory muscles. And that's kind of our classic emphysema patient, and he's doing that tripod sitting, trying to help himself breathe a little bit easier. Inspect the posterior thorax. Again, start with the skin, look at the tones of the skin, look for any abnormal lesions, so on and so forth, and check your spinal column, slope of the ribs, make sure the anatomy is appropriate. Look for any thoracic or abdominal respirations. Again, see if they're using any accessory muscle use because they're having a lot of distress. Check for intercostal retractions, and that's the muscles in between the ribs to see if those muscles are moving in and out. It's usually caused by some type of obstruction or they're having some really difficulty breathing. If they have any bulges in those intercostal spaces, sometimes that might be related to asthma, emphysema, or even what's called a pleural effusion. And that's kind of a area of consolidation or a area of accumulation of infection or fluid within the lungs. All right, the first thing we want to do is do just general palpation of the thorax, and again, we're just going left to right, and then you're going to check for masses, tenderness, or crepitus. I tend to use just kind of both hands, and I'll go down the chest, but you can go use one hand to go left to right, but again, we want to compare side to side. We're going to check for thoracic expansion. You're going to put your hands right roughly around the 10th rib and with your thumbs touching, and as they take a deep breath, your hands should expand a little bit. Normal is about 3 to 6, and it should be expanded equally. That's how far the thoracic cavity will expand on inspiration. And then tactile fremitus. So you're going to have the client say 99 as you feel with your palms. Again, that sensation is going to decrease over air and it will feel increased over fluid. So we start up here at 1. You put your hands here and you ask them to say 99. Move it to space 2. Should say 99. 3 and 4 and so on. I did demonstrate this in the demonstration video as well. Again, if there is fluid in the lungs, you're going to have an increase in those vibrations because, again, sound waves move a lot easier through fluid and liquid versus air. The percussion technique, again, typically this is something that students struggle with, but you're going to place that middle finger of the non-dominant hand and use the tapping finger of the dominant hand. I did do some percussion on the demonstration video as well. And here is our percussion landmarks. You're going to just basically assess for what type of sounds you're going to listen with your percussion, depending on the areas, whether you're over bones, masses, or those air-filled areas, what you're going to hear. And then you will, after you inspect, palpate, percuss, then we move on to auscultation. And you're going to use your stethoscope, and again, compare side to side. And then once you're finished with your assessment, then you identify where you heard what type of sounds at what part of the lung field. Whether they were bronchial, bronchiovesicular, or adventitious. Adventitious is the term we use for abnormal lung sounds. Inspection of the anterior thorax. Remember, going to the anterior side, again, skin. This is also, sometimes we do the trachea on the neck assessment, but really it is part of the airway because of that trachea, or it can be part of the airway because of the trachea. Make sure that trachea is nice and midline. Just note their respiratory pattern, and that includes the rate and depth of their respirations. Do they have any retractions or bulges within the intercostal spaces? What's the slope of the ribs? Hopefully their chest is rising and falling symmetrically. You don't have unilateral chest rise and fall. And check the AP diameter, the transverse diameter. I did demonstrate this in the video. It's a little hard not to do that in person or try to explain it in person. But ideally, the anterior posterior diameter to the transverse diameter should be a 1 to 2, okay? Thorax abnormalities, things you might see that are abnormally. A barrel chest, again, that's usually caused from emphysema clients or perhaps even COPD clients when they get a lot of air trapping in their lungs. Again, it kind of changes the structure and the shape of their lungs because they can't get all of that air out, and the alveoli get a little overinflated, and they tend to have a little bit different shape with their lungs. A flail chest is usually from trauma. That's when you have a lot of fractured ribs or even perhaps a collapsed lung, and you will have unilateral rise and fall of the chest. Like one lung will rise and fall, but the other does not. That is called a flail chest. A funnel chest, usually that is some type of genetic issue. It's pectus excavatum, or a pigeon chest is Pexis carnatium. Usually you might see that in disorders like Marfan syndrome or some type of genetic concern. Scoliosis, I think you're probably mostly familiar with scoliosis. That's the curvature of a spine. Sometimes that will have, you can see changes in the vertebral column, and it also can kind of change, it can, if it's severe enough, it can cause problems with lung expansion and their ability to breathe because of the way that the spine may curve and cause problems with the corresponding lung. Kyphosis, again, that's also curvature of spine, but it curves out, and it's kind of like a hunched back, versus the S with the scoliosis. Also can cause problems with the lung expansion. Here is that anterior, posterior to transverse diameter. If you look at our guy here, he's got a 1, like here, 1, this is 1 to 2. 1 to 2, 1, 2, 1 to 2. So this is 1 length compared to 2 lengths. That would be a normal adult. A barrel chest with somebody with COPD, you can look at the chest. It's usually almost like a 2-to-1 ratio on that. They have, it's more of a barrel shaped, so it would not be the 1 to 2 diameter like I mentioned, that 1 to 2 ratio. Hopefully that makes sense. Here's the pigeon chest, the funnel chest. Again, kind of has a concave there, or they have that, the sternal has kind of like that pigeon chest. Again, Marfan syndrome, some of those other disorders. The kyphosis, again, is the humpback. Scoliosis is that curvature of the spine. Again, both of those can compromise the chest space or the lung space. Then you're going to palpate that anterior thorax. Again, I did it bilaterally. You're just comparing side to side. And then you're going to, after you do your general palpation, you'll do that thoracic expansion just below the 10th rib, and then proceed with your tactile phremesis, and that's when you have your client C99. Again, I did kind of perform these in my demonstration. And then you do percussion. Again, you're going to do the percussion on your client and identify what type of sounds you were able to elicit with your percussion. Again, I encourage you to try to find those intercostal spaces. Generally, you're going to have some dullness over these 3rd to 5th intercostal space on this left side because that's where the heart is. And so it's kind of it's a muscle mass, and so it'll be a little bit, dull. Then you'll move on to your auscultation. Again, identify those lung sounds, whether they be tracheal, bronchiovesicular, or vesicular sounds. Look to your previous slide and just be able to identify those sounds where you would be able to hear them, whether over the lung fields, along that bronchial tree, or over the main stem bronchus. Geriatric variations include the respiratory rate may change a little bit because their lungs don't work as they're not as compliant as they used to be. Over time, just having infections or being exposed to toxins, pollutants, our lungs just tend to get not as efficient as they used to be. They're not as pliable. And they also have a decreased cough effort. There's a ciliary escalator in your airway, and that just becomes a little bit more stiff over time. Kyphosis, again, we tend to get a little bit more curvature of the spine with age and the more prominent rib cage. They do have decreased thoracic expansion. They just don't have the effort that they had previously, and they use more of their diaphragmatic breathing. Here is your concept mapping for your respiratory assessment. If you have any questions, please don't hesitate to let me know. I did add some terminology along for this because I know there's a lot of terms that you may or may not have been exposed to. Again, atelectasis, that's a collapsed alveoli. Some people call it collapsed lung, but it's different than a collapsed entire lung. It's really those collapsed grape-like clusters. And remember, pneumonia is either infection or consolidation of fluid somewhere in the lung. Pulmonary edema is when you get fluid in those air spaces or in the alveoli. Emphysema is that hyperinflated or air trapped in the alveoli. And consolidation, again, is fluid in the lung like you would see in pneumonia. If you have any questions for me, please don't hesitate to let me know. And I think that's it. All right, thanks.